So this webinar will be focusing on the Teratogens, the vigilance of medicines used in pregnancy, the safety of these medicines and their effect on birth outcomes. We have representatives from the World Health Organization who will be presenting on the pregnancy exposure registry projects that they initiatives that they're involved in, particularly focusing on how to improve drug safety among pregnant women for drugs used in public health programs. Lessons learned from Botswana, from the Tsepamo Study, where the initial dolutegravir-based neural tube defect findings were identified. Efforts also towards building a platform in Africa to support congenital anomaly surveillance and maternal infections such as Zika virus in these settings. So without further ado, I'd like to give you a little overview on the SCAN network. Next slide, please. Next slide. First, actually, before we start, let's do a little bit of housekeeping. The workshop, as you heard earlier, is being recorded and will be shared on the Global Health Networks platform. Please feel free to or any to the audience and to give us any technical issues you might be experiencing. Please use the question and answer box to post your questions and topics. We're really keen to provide make this as interactive as possible. So because of the number of participants we have and the camera and microphone, your camera and microphone will be disabled. But if you would like to speak when invited by the chair, that myself, please raise your hand and we'll be able to enable your microphone. Please use the chat function, as I mentioned, and message the Global Health Network team if there are any problems. Next slide. So just a little bit about this work. This is a seed project aimed at establishing an African congenital anomaly network funded by the UK MRC. The primary aim of the network is to improve the diagnosis of congenital anomalies and the care for affected children and families, and to promote identification of the causes of such afflictions. By building an evidence base through surveillance and research, by improving capacity for collaborative research in the region, and by paving an active pathway on policy and practice. So this congenital anomaly network was established with 10 African countries as partners. The network is led by a team of co-investigators working together across these African countries, as well as the UK and US. Together, we aim to establish a network that will build capacity by training health professionals with webinars such as these and other resources. It's really received quite a resounding amount of support already, and we can see from the numbers of attendees that the interest in this network is really growing, and we're very grateful for that. So the aim of today's webinar, as I mentioned, is teratogens and pharmacovigilance as part of the prevention of congenital anomalies. We will have our speakers from the World Health Organization discussing their initiatives with pregnancy exposure registries and pharmacovigilance in pregnancy, lessons learned from the Tsepamo study, and of course, our colleagues from Burkina Faso will talk about their congenital anomaly surveillance, focusing on Zika and maternal infections. Next slide. So our first speakers are from WHO. Gives me great pleasure to introduce our first three speakers. Dr. Marie-Eve Raguenaud is a consultant for the WHO TDR division. She works as a consultant to support implementation research projects that are taking place in low and middle income countries. Dr. Noha has been working for 7 years in the Pharmacovigilance WHO Regulation and Pre-Qualification Department. She has a specific focal interest in pharmacovigilance for public health programs, including maternal and neonatal health programs. And her focus is on active surveillance systems to support pharmacovigilance. Dr. Francoise Renaud has been working for WHO for more than 20 years, largely in the field of HIV. She is the technical lead of the Strategic Information and Analysis Unit for the Global HIV, Hepatitis, and STI program in Geneva. Since 2013, she's been leading patient and toxicity monitoring network for HIV, hepatitis, and STI programs. And so her work consists mainly of producing updated norms and standards for safety surveillance, including, of course, antiretroviral surveillance and patient-centered HIV patient monitoring for improving health outcomes and driving impact in countries. So without further ado, I will hand over to our colleagues from WHO to present. We'll start with Dr. Marie-Eve. Thank you.
Yes, thank you. So before we hear about the prospects on the pharmacovigilance and the HIV departments of WHO, I will start with the Central Pregnancy Registry. Do you see it?
Yes, we do.
Okay, so I will briefly describe how it started, its purpose and general operation as a central database and its key components. So first, the rationale about the Central Pregnancy Registry. So after it was observed that there was a lack of data on medicine use and impact on birth outcomes in sub-Saharan Africa, and at the same time, large-scale deployment of medicines for malaria, HIV, and TDs, it was thought that there was an opportunity to work together with ministries of health to monitor the safety and benefit of drugs in pregnancy. And so in 2012, Dr. Ushma Mehta, who's here with us, and a group of experts led by WHO, developed a generic protocol for a pregnancy registry that would be adapted to resource-limited settings. And this protocol provides guidance on how to set up such a registry in sentinel health facilities where women come for prenatal care and delivery. Key outcomes were defined, and this protocol also included case record forms and training material. And one of the objectives of this registry was to provide information on the safety of medicines in pregnancy. And it was assumed that individual countries will pool their data into a common database, a central pregnancy registry. And the advantage that we get from that, from pooling the data from different countries, is that you have bigger cohorts that are more representative and that facilitate the detection of a rare safety signal. So that was the idea. So specific objectives of this WHO pregnancy registry were defined to facilitate the collection and harmonization of data from different sources, to maximize the potential of existing data, to enable early detection of a safety signal, and to inform treatment guidelines. The data providers were expected to follow the recommendation of the generic protocol using the materials that were developed to obtain reliable data on drug exposure, and basically respecting the features of a pregnancy registry, which are listed here. So a few years later, the central database was set up. How does it work? Individual countries and projects or study sites can contribute their individual patient data. Of course, there are some criteria to fulfill in terms of compatibility and quality of data. And for that, there's a list of key variables that was developed. There's also a data dictionary that can help data providers. The data that's shared is de-identified, anonymized, and should not include any names, addresses, but ideally should include date of birth. The export to the central database and curation is facilitated by TDR for the moment. So this is where where we intervene. So we are in contact with the data provider. We decide together which is best, whether they can send the whole data set or a subset of the data for us to check before sending the whole data set. And before any data sharing is done, we make sure that the contributor agrees and signs the data sharing agreement that stipulates the purpose of the sharing, the conditions, and the use of the data. So here is a summary of the key components going from the data acquisition to the data sharing, the data curation, data storage, and data usage. One of the key points is that the data contributors remain the data owner, and they can, of course, use their data as they wish. For the data sharing, so we discussed that. The key point is that there is this signed agreement before any data transfer. For the data curation, we rely on a computing firm that is a subcontractor of WHO and that does the programming for variable matching and data quality control. The data is stored securely for a time-limited period that's mentioned in the data sharing agreement. And as for the data usage, one important point is that the only objective of the analysis of the pooled data is to generate evidence for the treatment guideline. Another point is that WHO does not provide access to the data to a third party for analysis that are not subcontractors. Today, we can say that we are at a standstill. We have data from 1,772 births, which are not recent. They're from the feasibility study that was done in 2012. They come from 4 countries. But a few days ago, we received a huge data set from the Tsepamo project. And we hope that other projects and countries will contribute in the future. After this pilot phase, TDR is planning a handover of this registry to the WHO Pharmacovigilance department. And I will finish here and pass on to Noha, who will take over. Thank you. So I will move the slides for you, Noha.
Thank you much, Marie-Eve, and thank you very much, everyone. Okay, so my name is Noha Iessa. I'm from the Pharmacovigilance department, as Ishma has introduced me. And Marie, if you just please go into the other slide. What I'm going to do is I'm going to describe some of the activities that we have already started with regards to monitoring the safety of medicinal products in pregnancy, and go on to what we are currently doing, and then explain how all of this will feed into our plans with what we're going to do with this register. So just to start with, the work that we've been doing, one major project that we've been working on over the last few years was the safety in pregnancy in a multi-country collaborative study. And one aspect of this is applying the Gaia case definitions, which were developed, case definitions on 21 obstetric and neonatal outcomes, and via the Brighton collaboration method. And we assessed how applicable this was in 7 countries. So the 7 countries that you can see are on the slide there. 6 of them from low middle income countries and 1 high income country. And the results of this study has recently been published this week, which can be found in the vaccine publication. This study was mainly done on immunization, maternal immunization. And there are following other publications that will come out of this project, but this is more or less what we've started doing. And to move on to the next slide, I'll explain what we are currently doing. Next slide, please. So at the moment, we're working with various partners, collaborating with PATH and on a landscape analysis of pregnancy registries globally. So we're working on finding a mapping of what is being done in different countries. So we will have that as a resource, so we know what will be done, where and who's doing what type of medicines or vaccines are being looked at, what kind of registries are available. So we have an idea of where the capacity is to collect information, what kind of improvements need to be, and so on. We'll continue working on harmonizing safety monitoring during pregnancy, which was started with the Gaia project with the classifying the outcomes. So we continue doing that. That's the second project we're working on. And a third is we're working with the monitoring the safety of COVID-19 vaccines in pregnant women. So there is an overall study in WHO looking at the safety of the outcomes, the pregnancy outcomes of COVID-19 in pregnant women in general, but we're adding to that a special part or component to do with vaccine safety. To the next slide, please. So what are we going to do with this registry that TDR had started earlier on? So it's going to be transferred to the pharmacovigilance team, and our plan is to review it because, as Marie-Eve said, that it came to a bit of a standstill for the last few years. It kind of stopped, and we stopped receiving any data there. So we want to review and see what the problems are, what the challenges are, and what the pluses are, and learn from them, so that we can then apply it later on, and we can use that to strengthen what's already existing, and we can find, we'll have an idea of what already exists from the mapping exercise, but we can strengthen registries in countries where they exist. And then moving on to that, we'll expand, we can expand it to, because I mean, this is the registries that Marie-Eve had described were a main sort of diseases, malaria and HIV. So we can then afterwards, once we strengthen what's existing, we can then expand to other disease areas. Over. Thank you. The next presentation will be on, over to you, Oshma.
Thanks very much, Noha. And we, it's very exciting to see the work so far. And I'm going to just ask Francoise to also speak about the antiretroviral work as well. Thank you.
Hi, everyone. And thank you really to the organizers for organizing this webinar this afternoon. And what I'm going to share now is really complementing what Marie-Eve and Noha have presented from the WHO and the TDR perspective. I'm going to share with you the angle and the interest in surveillance of safety of drugs in pregnancy by the HIV department, what is of concern to us. And it's really about using safe ARVs in pregnancy and the need for strengthened surveillance. Next slide, please. And when we speak about safety of drugs, of ARV drugs and strengthened surveillance, we are really addressing the specific needs of a large proportion of people in need of ART. Just a number of figures here. It's more than 19 million women living with HIV globally, and an estimated 720,000 young women and women who were newly infected with HIV in 2019, large numbers. And worldwide, we know that an estimated 44% of all pregnancies were unintended during the global period of 2010-2014. And there was an estimated 1.3 million births to women living with HIV in 2020. With expansion of the treat all with the ART, increasing numbers of women are conceiving while already receiving the life-saving antiretroviral therapy. We know that physiological changes of pregnancy can affect drug absorption, distribution, biotransformation, and elimination. And also delaying introduction of new ARVs for pregnant and breastfeeding women would limit regimen harmonization across populations and in turn impede ART scale-up effort and including saving lives of the woman and preventing vertical transmission. So these are the scope from the HIV angle of the topic and the challenges. Next slide, please. It's fair to say that new drugs are rarely studied in pregnancy. 80% of women take a drug in pregnancy with minimal safety and efficacy data worldwide. We've done somewhat better than that for ARVs, and historically, the mean time from FDA drug approval to first published PK data in pregnancy is 6 years. And most of the published data were obtained post-registration through opportunistic PK studies among women that were receiving a specific agent and who became pregnant and agreed to stay on treatment and consent to the PK data. Next slide, please. These findings were stitched together into a framework to accelerate the inclusion of pregnant women in registrational trials. And as you see on this slide in the part below, so with earlier completion of non-clinical trials, which will allow women who become pregnant in registrational trials to elect to stay on study drugs and collect PK and safety data, and enrollment of pregnant women into PK and safety studies, and once the PK is determined, conducting dedicated pregnancy safety studies, no later than early post-approval for priority agents. So this framework is presented to you today to also say that, you see, as new drugs will become available on the market, we want safety data earlier. We want to accelerate the studies of these drugs in pregnancy. But of course, and this is the link with this webinar this afternoon, it means we need surveillance systems to collect high quality data on large numbers of exposure to complement and have a surveillance at long term of the safety of these drugs. Next slides, please. This is to show you how it works and how surveillance of safety of ARVs in pregnancy has played a major role in informing HIV treatment policies in WHO. So just some key dates to share. 2016, we published the WHO consolidated guidelines on the use of ARVs. We updated the guidelines, and there were two major changes. We had safety data on the use of tenofovir during pregnancy, and we shifted from nevirapine to the use of efavirenz in pregnancies, especially for safety reasons. And the safety adverse events were coming from surveillance data, mostly from South Africa, if you remember very well, for those who are on the webinar today. So from that changes in the guidelines, large surveillance programs were established. And these were the first ARV pregnancy registers that were implemented in Malawi, in Uganda, and also the large surveillance program like in Botswana. And we were reassured that there was continuous surveillance of the safety of the drugs implemented while people were exposed to the drugs and the programs were scaling up. However, as you know, in May 2018, there was the safety signal, and I would emphasize the terminology signal, because you know very well that signal doesn't mean the drug is not safe, but there were some data that were suggesting that there was a potential safety issue of neural tube defect with the use of dolutegravir. So what we did, we created a WHO safety subcommittee for dolutegravir to review new data as they would become available. And we have reviewed a number of sources of data. And in July 2019, we were able to receive, in view of the new results, especially from the Tsepamo study that Rebecca, I'm sure, will present into details in the next presentation, we were able to receive the green light from the WHO Safety Committee to the use of ARV during pregnancy. And it's very important, and I really would like to insist, because we know that there are some countries that are still a little bit hesitant, while really the guidelines have confirmed, and we have revised and updated and confirmed the guidelines since July 2019 that DTG can be used for treating all, including pregnant women, including at the time of conception. Since 2019, we have done some work that were presented in the framework below, because we see that we are lacking of safety data, and we want to have more data earlier for the use of the new ARVs in pregnancy. So we have initiated this work with the impact. In 2020 and 2021, we have also updated the guidelines in July, confirming the use of DTG, but we highlight a few key issues with some new drugs, including TAF, where we would see some weight gain issues in large population, but including also in subpopulation like pregnancy. So we are continuously looking at the new data and the programs that could generate the safety data. We need to update the policies for the use of the new drugs. So looking onwards, and I think this is very important for the people in the countries, we need safety data, and we need comprehensive strategic surveillance as new drugs are introduced. We will have new formulation, we will have long-acting ARVs, we have already cabotegravir used for PrEP, we have new molecules. So we really, this is a strategic webinar, and I really very grateful that we can discuss this today. So where are we with surveillance? So next slide and final slide, please. So surveillance is critical. We know all very well that we cannot expect to have clinically meaningful data on teratogenicity risk from trials, because the size are too small and in times it's too limited. So we need surveillance. It is critical for rare and long-term outcomes. But there are a number of remaining challenges. Often, especially with the voluntary registries, we have unknown denominators, reporting bias, underreporting. We have few data sources from limited settings. Most are coming from North America or from Europe. And we have often incomplete or inaccurate data from routine medical records. So we have worked on a number of potential solutions to work on a common framework for strengthening ARV surveillance. The first one, and my colleague Noha already highlighted it, is to work and adopt harmonized adverse pregnancy, birth, maternal outcomes definitions. So we can harmonize and we can share and we can review the data in a meaningful way. We need to establish surveillance centers of excellence in areas with high HIV prevalence. We need to harmonize data collection procedures and also leverage and optimize electronic health records, link maternal infant data. And finally, we propose to create targets and monitoring and evaluation goals so we can each year, we say what is measured gets done. So each year or every 2 years, we can measure the progress that we have done in implementing good quality surveillance. Next slide, please. So this is to thank my colleagues who have contributed to this work with me, and also to thank you all. Thank you very much.
Thank you very much, Francoise, Noha, and Marie-Eve. We have a few minutes for questions. So if there are any questions, you can either post it in the chat, or will facilitate your access to the screen. I also want to just, while we're waiting for questions, I wanted to just say that it's really fantastic that there's this collaborative and cross-cutting approach that WHO has taken to looking not just at pregnancy registries for a particular set of drugs, but really looking at them as a resource for a variety of treatments. And I think perhaps maybe, Noha, you could comment on the use of these existing registries for COVID vaccine surveillance.
For COVID vaccine surveillance, there haven't been so much particular registries that we have direct contact with, but we intend to roll out a study that we will be working with the other teams within WHO that are looking at maternal outcomes on COVID in general, and we've collaborated with them to add into the study the component of the vaccine safety. But we don't necessarily have access to registries at the moment, but we have worked on documents to help guide countries on how to monitor the safety in pregnancy and lactation of COVID-19 vaccine. So we've providing guidance and support to countries, but I mean, it just, if a country requests from us, we're happy to support, but we haven't have any direct registries at the moment for COVID-19.
Great, thanks. But I think it's there are some in the high income countries that have been set up. But I think your point is valuable, and I think all of you have raised this. The issue of providing support and a framework that sites, countries or groups that are interested in setting up registries can use the resources, the standard case definitions, the data exchange standard that WHO has on their website to help to establish their own systems. But that is in relation to a question also that's been asked, is does the WHO plan on supporting countries to establish networks, I presume networks of surveillance for pregnancy registries? So, okay, I'm sorry, I'm just seeing a little pop-up here. The host has spotlighted your video for everyone. Okay, thank you, sorry. Do you still hear me? Yeah?
Yes.
Sorry, I just got an odd pop-up. So I think that you have raised that point, but if anyone wants to speak a little bit more around how other ways in which you're supporting countries keen on setting up surveillance platforms for pregnancy.
I can give an example if you want, Noha.
Thank you, Francoise. Yeah.
Sorry, I have two cats fighting across the door. I hope it will not. It's incredible. For example, Eswatini is starting a surveillance project for 1 year. And the way we support is technically from the WHO side, and we are also supporting that the key actors speak to each other. And I would like to say that there is already an exchange of the minimum data set and the tools that are used in Botswana by the Tsepamo Study to the Eswatini team, so they don't have to reinvent the wheel again, and to make sure that this harmonization exist already. So so really I think technical collaboration is key, and the way we support it as well is to and we've done that in Malawi before and in Uganda, is also to make sure that the Ministry of Health is at the center of the program, because as you said, Ushma, I mean, often it's the HIV field that is initiating, you know, the interest and the dynamism, but the interest for everyone, including for us, is that it covers all the drugs used during pregnancy, and we can see also the issues of drug interactions and comorbidities. So really, we make sure that the MOH is at the center and works with everyone in the country to make sure that we capture drug exposure during pregnancy from a comprehensive manner.
Thanks, Francoise. I also have another question and I think it's more a clinical question, is how to manage and treat pregnancies during the COVID-19 pandemic, monitor their safety and condition. So I think, are there guidelines that WHO has made around managing pregnant women with COVID-19? I think that's I get a sense that that's the question. Yeah.
And there's, I mean, in the pharmacovigilance aspect, there is the guidance document to help monitor the safety of the vaccines in pregnancies. But to manage, then there may be something in another department from pharmacy, from WHO that may have been published. But I'm aware of the pharmacovigilance aspect, but actually managing the safety of the condition, I mean, I think it's an evolving an area at the moment. We're learning more about it, and I think the focus at the moment is more to learn more about it so that they can eventually have a guidance document. But as far as I understand, there's definitely guidance on monitoring the safety of vaccines in pregnancies.
Thank you. Thanks, Noha. And I think the focus of this webinar in particular is around monitoring the safety of these of the drugs and the disease and the outcomes, rather than on clinical guidelines. But I just want to raise also this point that there is growing evidence of the safety of the COVID vaccines in pregnancy, and that really is one of the best approaches to reducing severe COVID disease in pregnant women. And we know that pregnant women are have a particularly high risk of contracting or having severe COVID disease. So, I think. Thank you very much. We are a little bit behind time now, so I'm going to just move on. Thank you very much to our colleagues from WHO. It's really great to see that there's a global approach to trying to bring and to build capacity in this very important area. Our next colleagues are from Botswana. Dr. Rebecca Zash, whom I'm sure many of you know, became quite famous when her signal around the risk between dolutegravir use and neural tube defects was published. And she's a practicing infectious disease physician and research associate with the Botswana Harvard AIDS Institute partnership. Her research focuses on antiretroviral medications in pregnancy and improving birth outcomes for pregnant women living with HIV. And Ms. Modiehi Diseko is a trained midwife who's been working in government hospitals in Botswana for many years and joined the Harvard Botswana AIDS Institute partnership as a research nurse. And she's been working with Rebecca on the Tsepamo Study since 2014. And I'm sure she has an enormous amount of experience to share with us today. So without further ado, I'm going to hand over to this team for their presentation. Over to you, Rebecca.
Modiehi, would you like to start?
Yes. Thank you very much, Rebecca, and good afternoon, everyone. I just want to thank the organizers of this meeting for inviting us to come and speak with you today. So I will be speaking with Dr. Rebecca on the discussion of our experiences communicating the unexpected safety signal for neural tube defects with exposure to dolutegravir at conception in the Tsepamo study. Next slide, please. So just to remind you where Tsepamo started the origins of our study. Back in 2012, the efavirenz was rolled out as part of the first-line ART treatment. And again, this was done in countries with high prevalence HIV, and this included Botswana. So efavirenz was previously avoided in childbearing women. I think, as we know, it's because of the concerns for CNS defects seen in preclinical monkey studies. So since efavirenz wasn't being used in pregnant women, the safety data was lacking before this rollout. But then in 2013, a pilot study was done in Botswana, which found improved birth outcomes among those who started efavirenz during pregnancy, as compared to the older regimens with nevirapine and lopinavir. So the Tsepamo study was funded by the NIH in 2014 with two primary aims. The first one was to evaluate the adverse birth outcomes by HIV status and ART regimen. And then the second one was to determine if there was any increased neural tube defects among infants exposed to efavirenz from conception. Next slide, please. So the Tsepamo study was rolled out in 2014. We abstract data from medical records for all deliveries across the study sites. We covered about 45% of all the deliveries from in Botswana from 2014 to 2018. But then we expanded our abstraction up to about 70% of all the deliveries since 2018. So in our study, when an abnormality is identified during neonatal surface exam, the midwives notifies our staff, the Tsepamo staff, so that they can approach the mother for consenting, so that they can do a photograph on the infant abnormalities. And these photos are reviewed by an expert in the medical geneticist who specifies the diagnosis. So even though our study was initially focused on efavirenz, we also started to gather information on dolutegravir after it was rolled out in 2016 in Botswana, while our study was still ongoing. Then we pre-planned our analysis for our two primary aims before we started Tsepamo. So for the first aim, we planned to do a 2-year analysis in 2016. And then for the second aim, which focuses on neural tube defects, we planned that analysis within 4 years of data in August 2018. And then because it would give us sufficient power to rule out a 2-fold increase in NTD with efavirenz. Then, as I mentioned earlier, DTG was rolled out in 2016, but there was no animal or other data to make us worry about birth defects with DTG. So we didn't specifically look out into this data. And then in 28th of April, just about 4 months before our planned analysis for AIM2, we were then asked by the WHO to provide any preliminary data available for their upcoming HIV guidelines committee meeting for the DTG from conception. Because we were the only people in the world collecting this data at this time, and the WHO really wanted to make this to make DTG as the first line preferred regimen for everyone. Next slide, please. And then in almost exactly 1 month from the time we received the request, everything turned around. Our world was exploded. I put this timeline in order to help us and the rest of us as the panelists and the viewers, the listeners, that how we received the request, and how we had to do this quickly and had to make decisions, and probably why we didn't have much time to think about all the broader implications of the data we were about to share. Basically, after the email request from the WHO, we made a study team to a decision to proceed in giving the WHO our confidential data on birth defects we found among those on DTG at conception. This analysis was performed in April 23rd, 2018, and uncovered an unexpectedly high prevalence of NTDs among women on DTG at conception, which showed 4 out of 426 women, almost 1%, which was nearly 10 times as high as we expected. So the analysis was repeated and independently verified by other study team members, and we quickly decided to proceed with an expanded analysis to evaluate NTDs in all of our comparators groups. So over the next week, it was all hands on deck in Botswana and Boston as we quickly but thoroughly cleaned our data and performed the full analysis. I don't think anyone slept at that week, and we felt the pressure not to make any mistake. And in this analysis, we found that the NTD prevalence with DTG at conception was higher as compared to the about 11,000 women on other ART regimen at conception, and among 66,000 women who were HIV unexposed, who were in HIV negative. So within 3 days, we had developed an analysis report and first presented data to the Ministry of Health in Botswana, and then later that day to the NIH, to VIV, which is the company that manufactured the dolutegravir, and then to WHO and to PEPFAR. That same week, we presented to the Botswana HIV Guidelines Committee, the CDC Botswana, and submitted our data to the upcoming International AIDS Conference, the IAS. And then finally, on May 17th, to a large group at WHO Guidelines Committee meeting. Basically, we were making this data public on that very same day. Next slide, please. The first and most burning question that came up was, how should we share the data? Once we saw the results, or whether we should share it at all or not. On one hand, the number of NTDs, 4, was very, very small. But on the other hand, the prevalence of overall NTDs was very high, 10 times what it should have been. And the broader context of the DTG was planned to be announced as WHO first line. So you can see how we were put in that tight corner in terms of decision-making. So with a massive rollout of DTG by PEPFAR to countries with a high HIV prevalence in people of reproductive potential. So for us, we had not expected these results, and we did not have any plan on what to do. Unlike a randomized trial, our study was observational, and we didn't have a DSNB or any safety endpoints or any international guidelines to follow. So what we did was to contact our most trusted colleagues from Harvard, Botswana, WHO, NIH, and PEPFAR, and we asked for undisputed decision about whether to share the data or not. Everyone agreed that it was most ethical to share the data. So I will add here that this group did not include anyone who represented the communities of people living with HIV. And as we will talk about later, and as we will talk about later in our talk, I believe it was a mistake that we did of not involving this particular group from the beginning. And this is the summary figure that we came up with to try to show all the points we were to make. One important decision was made here, as you can see on the next, the red line, is to use prevalence difference instead of risk ratio or the odds ratios. We did this because it seems that showing risk ratios that were very large, like 10 to 20, would be too scary. And that prevalence difference would be more fairly reflect than overall chance of having an NTD was still very small. Next slide, please. So after figuring out how to present our data, it quickly became clear that people were not just going to accept our findings. And I know that this is very common. People need to think and make a decision. So I think the reason why for this were many, but included that naturally people didn't want to believe the bad news. We know this is very common. We only want the good part, not the bad. So that many people were looking at our data. They did not believe they could trust data from Botswana, as we know that we are from the lower resource setting. And many people also, they doubted our study because it was observational and wanted to see the result from a randomized clinical trial. Even though we actually can do RTCs for conception exposures and rely on observational data. But then some of the ways in which we presented our data to help build trust in our results included, the first one was to show high quality of data collection, starting with 99% of infants having an exposed infant surface exam. And the second one was having a well thought out comparator groups that were both very large and also very fair comparisons, including similar populations, looking at those with non-DTG at conception, and also general population without HIV. And the third one was tracking an internal comparator defect, which was the extra digit, just to show that all babies in the study were being evaluated in the same way, that there wasn't some different being done in those exposed to DTG. So, and then we came up, then there was this hard question that came up for us. How should we interpret the data? Our initial approach was to try to remain impartial, to present research findings, and then let policymakers and clinicians to decide what to do with the data. We did this because we really didn't want to be biased, and also because we didn't know what should be done. The way we messaged this in our first conclusion statement was that we just have this concerning early signal for DTG and NTDs that required further surveillance, and we left it like that. And I think Rebecca will continue from here. Thank you very much.
Thanks, Moriaki. Yeah, and so after we sort of put out our initial interpretation of the data, pretty much the same day, the next day, the WHO, the FDA, the EMA put out warnings on the safety signal. And this really kind of took the messaging out of our hands at this point. And I think what we saw was that the initial message globally was really focused on two things, that there was this preliminary safety signal. So at least we agreed it was preliminary, it was a signal, it's nothing proven. And then the second part of a lot of the messaging was that it's suggesting dolutegravir is not safe. So it was really focused on safe versus not safe in early pregnancy. And, you know, there was really no easy solutions about what to do from an early safety signal with such a, you know, a bad outcome. And places did things differently, and people took our data differently. Some recommended different ARVs, which didn't have any of the same data as dolutegravir or efavirenz. Some recommended DTG for men and efavirenz for women, which created some gender inequity. Some places required women to prove they were on effective contraception to get DTG, which became a very large barrier to getting HIV care. And some places recommended individualized treatment choices, which is, you know, a very wonderful approach, but trying to do it in settings that weren't prepared for this, where there was little treatment literacy and more than 50 patients per clinic session, was just logistically very challenging. And I think what the big thing that we realized and probably should have thought of, but didn't necessarily, was that this signal, this pregnancy safety data, really didn't just impact pregnant people, it impacted everyone. And after releasing our results, what happened was that a lot of women around the world couldn't access DTG. The rollouts were slowed, and this worsened existing inequities in treatment, both between richer and less rich places, as well as by gender. There was also many important HIV clinical trials that were ongoing or planned that were paused and delayed because of this signal. And this was really unfortunate because the background is that DTG is a overall better antiretroviral drug than efavirenz. It's better tolerated with less resistance, and it improved viral suppression. And you know, a lot of what happened was that there was community outrage, and a lot of this was led by the AfroCab of women in Africa, really protesting to be allowed to make their own decisions for their bodies about the antiretrovirals that they take. And then, you know, the other thing that happened from this messaging is that I think clinicians, who are the ones who have to actually make these decisions on the ground, were confused. This is data we collected in Botswana, and on the left side here, the blue bars are people on DTG at conception. And in these few months after the safety signal and the few months before the safety signal, there's really no change overall at the proportion of women on dolutegravir at conception. On the other hand, what happened is that almost immediately after the signal, clinicians on the ground stopped prescribing dolutegravir to people who are already pregnant, typically after 12 weeks of gestation, and started providing efavirenz instead. So again, in terms of safety against the signal for whatever it was, it made no difference, the change in practice, to who was actually at risk because they had to be on at conception. But we started providing a lot more of a less well-tolerated drug during pregnancy after this risk period was already done. And, you know, I think that what we see in retrospect is that this really did cause harm, and it wasn't just sort of theoretical harm. These are two models that were done published in the early 2019 after the signal. And this one up here kind of shows you nicely that if we were to use a dolutegravir-based regimen over a 20-year period, basically there would be both harms and benefits, but the harms would be fairly small in that there would be two more neural tube defects and one more neonatal death. But because dolutegravir is more effective at viral suppression, there would actually be 38 more women alive, 35 fewer sexual transmissions, and 29 fewer transmissions, vertical transmissions to infants. So really it did have, you know, this discussion started late, but we then started really thinking about this in terms of weighing the risks and the benefits. And so again, the initial reaction focused on this increased risk, or is it safe, is it not safe? Will we confirm or refute the signal? A lot of sort of dichotomous things that were really hard to quantify. And what we wanted to do was shift this narrative from safety to a narrative of what are the risks and the benefits. And I think by late 2018, it took a while, but we were emphasizing that we really didn't need to wait to confirm or refute the signal, but that we could make decisions about dolutegravir by weighing these risks and benefits and determining if the benefits of dolutegravir outweigh the risks. And then the other thing that we felt was very important as the researchers was to get as much data as quickly as possible. So Tsepamo extended its planned analysis from 2018 to March 2019. We expanded our sites more than double to 18 so that we could capture about 72% of all births in Botswana. And we formed a study monitoring committee that was non-Tsepamo people who would review our data every 3 months, and we would make a collective decision about whether we needed to go public with the data or not. And I think, as everyone knows, what happened, which was fortunate because we didn't know at the time, was it going to be, 5% neural tube defects or not? But a year later, we got the data, and with more additional exposure, with 1,200 exposures, the prevalence had gone from 0.9 to 0.3%. And again, we chose to present this as a prevalence difference, which, although was still statistically significant, was incredibly small. And you can kind of see the shift in the messaging when we concluded our IAS presentation with the 2019 data compared to the 2018 data, is that we really wanted to interpret our data and help people understand what we thought should be done with the data. So while this is actually taken directly from the slide, we said that the prevalence of NTDs remains slightly higher than all the exposure groups, but emphasized that the estimated difference is very small. And then we added that we thought clinical and policy recommendations based on these findings needed to consider the small potential risk of NTDs compared with large projected benefits of dolutegravir, a lack of similar data for most other modern antiretrovirals that would be acceptable alternatives to dolutegravir, and that there were many other unknown risks, with exposure to ARVs, such as long-term neurologic outcomes and abnormalities that we could not measure in Tsepamo. And I think one of the reasons we shifted to sort of lending our own voices into what should be done is because we realized that, we were actually probably the most, we had the most knowledge of the data. We were involved in lots of conversations. We were seeing all other people's data, and we actually had something to offer, and that we wouldn't actually be being biased. We would actually just be helpful to the world, and nobody had to take up our recommendations. But we felt like we had something to say. And then the other thing that we did, because, honestly, it had been a very, very hard year, and we felt kind of like the bad guys, and we didn't like being in that position, and it was kind of depressing, and we really, made it very hard for not only people making policy decisions, but people living on the ground with HIV and not knowing what to do. And it was very depressing, to be honest. But we did realize that we could sort of add these advocacy messages on to our presentations. And these are things that we had cared about for years and years, and why we did Tsepamo in the first place, and that maybe something good could come of sharing this bad news. So, in all of our talks, after a while, we started really discussing a lot of things that you heard earlier from WHO about how we need pregnancy safety data to maintain gender equity, that we need these sustainable surveillance systems in high burden countries where surveillance hadn't necessarily been occurring, And then, really refocusing on how we really needed to improve contraception and integration of reproductive and sexual health, and fully fortification of foods, including a wide variety of community voices in both policy and research from the beginning. So we tried to make these messages part of the sort of the bad news about NTDs. And then, bringing up to the present, we continued to do Tsepamo. And I think probably, again, everybody knows this, but the signal, again, has continued to decrease, has continued to be extremely reassuring for dolutegravir. And in July, we presented at IAS with a prevalence of 0.15% in almost 6,000 exposures to dolutegravir at conception. So I think as we sort of had the heat taken off of our study, as the dolutegravir became more and more widespread, first line in guidelines all over the world, we were able to reflect on, what had happened and what we could have done differently and what kind of lessons we learned. And we've had a lot of these discussions as a study team. I think the major lesson that we would want other people to know is that focusing only on risk really can cause unintended harm, and trying to avoid this dichotomy between safe and unsafe, and really instead use risk, benefits, and balancing, emphasizing the magnitudes of the risk compared to the magnitudes of the benefits. And this has become very clear, not only relating to birth defects, but really relating to all sorts of medical interventions. And when we do a lot of work now around COVID vaccines, I find myself thinking back to these same principles. Then the other things that I think are very important, as I mentioned earlier, to evolve, in fact, affected communities from the very beginning. I think we could have better anticipated some of what would have happened if we had those voices in at the very beginning. Develop better messaging and outreach to clinicians and not just policymakers, as the clinicians are the real ones who have to make these decisions in real time. That staying impartial and is not necessarily possible. People want to know your opinions about the data, and you're really closest to the data and probably have a lot to share. Important to find ways to include advocacy and make an upside. And then, finally, if we could have gone back and done this again, we wish we had a plan for unanticipated outcomes before starting the study. And that leads me to my last slide, which is how we're trying to address that now. Dr. Roger Shapiro, who's the PI of Tsepamo, has recently gotten a PO1 grant. And there's a couple different projects. The first is to continue Tsepamo, which is exciting. But the second project is in collaboration with our statistician friends, and is going to aim to evaluate methodologies to develop reporting criteria for pregnancy surveillance cohorts, so that it's much easier to make sort of a data safety plan for observational studies like RCTs going forward. And I'd just like to, there's so many people to thank who have made Tsepamo possible, including all of our research assistants and the Ministry of Health and Wellness in Botswana. Thank you.
Thanks very much, Rebecca, for really actually quite an interesting encounter, sort of getting to know the story behind the signal, which is really fascinating and very useful in terms of lessons learned. Unfortunately, we are running a little late, so I'm going to go straight into our next speaker, but perhaps at the end, if we have a little bit of time, we can entertain some questions. Apologies, but I think we just need to make sure that we've got a little bit of time at the end. So our next speaker is Dr. Eric Nebier. Is a physician specializing in tropical medicine and clinical research at the National Institute of Public Health in Burkina Faso. Eric is a WHO TDR Clinical Research Career Development Fellow, and also an alumni from the African London Nagasaki program. Eric's research interests focuses on clinical research, efficiency, improvement, tropical diseases research, innovative health interventions, implementation and health system preparedness to health shocks. such as pandemics. So over to you, Eric, and welcome.
Thank you to all the panel and all the participants to this webinar, and thanks for organizing this webinar and allowing us to contribute in this work. So I will present on behalf of Dr. Ali C, who is the PI of this project on the establishment of congenital anomalies platform in West Africa, in Sub-Saharan Africa, like similar like the ESCAM. For this talk, we will present the rationale of our study first, and we'll also discuss how we are going to conduct it and what will be the potential impact for this project to be conducted. As you know, since the 2015 and 2016 Zika virus epidemic in Latin America, it now became clear that Zika infection is associated with congenital abnormalities, particularly with severe microcephalies. What is not clear for us until now is that we don't know if similar epidemics could occur in Africa, knowing that Zika originating from the Zika forest in Africa here. Besides of that, we are lacking a surveillance system and even a reporting system for microcephalies, and we have been discussing this during the previous webinars. This is making congenital abnormalities a silent public health concern for most of the low-income countries. There are several etiologies for these congenital abnormalities, including the complex TOSH infections, toxoplasmosis, rubella, cytomegalovirus, herpes simplex, and syphilis. We are also Zika also leading to these congenital abnormalities. But we are lacking a clear system for screening of these major diseases. For instance, in Burkina, we only have toxoplasmosis and syphilis screening, systematic screening in the preconceptual period or during early pregnancy period. In addition to that, we are also lacking facilities to diagnose early congenital abnormalities and even to manage them in our settings. This is stressing the need of having a correct diagnosis tool and also having a clear management plan and raising awareness about these abnormalities and the infectious, toxic, genetic, and environmental causes in our settings. So given that, we decide to conduct this pilot project, which is aiming to demonstrate the feasibility of generating baseline data on this congenital abnormality in rural area. We'll also have to develop first-line lab testing for these agents causing congenital abnormalities in our settings. We are aiming to generate baseline data for FC conferences on the congenital abnormalities in Sub-Saharan Africa, and we'll also assess the current services offered for children born with congenital abnormalities. We'll provide a basis for a future platform for congenital abnormalities in Sub-Saharan Africa, and we will evaluate the global birth defect application with going to be used for this congenital abnormality surveillance. We'll conduct this study in two settings mainly. In Cote d'Ivoire, in Tabo HDSS, the elephant demographic surveillance system, where we have 48,000 inhabitants under regular follow-up. And the second setting is in Burkina Faso, in the Centre Noha, where I'm originating from, and belonging to the Institute of Public Health in Burkina Faso. We have 126,000 people under regular follow-up with a birth cohort of over 3,600 newborn per year. For this study, we are going to conduct a quantitative component, which will be a descriptive cohort study of pregnant women and the newborns, and we also have a nested qualitative study, which will run over 2 years. We'll enroll in this study 3,000 mother and newborn pairs, 200 in Noha HDSS and 2,000 in Noha HDSS and 1,000 in Tabu HDSS. For the quantitative components, we'll have 3 visits mainly. The first visit will be at during the 3rd trimester of antenatal care visit. The second visit at delivery up to 3 days after delivery, and we have a follow-up visit at day 45. During this visit, we'll have a health component measurement. We'll measure it 3 times, and all the 3 measurements will be recorded, and we'll harmonize this and standardize this measurement across the 2 sites. Then we will screen all the participants for TORCH infections and Zika infections. We'll measure also the hemoglobin level, and we'll only carry karyotyping for children with congenital anomalies who will be found in this study. We'll collect the data only in health facilities, and we'll collect clinical history of pregnancy and birth. We'll also document all the concomitant treatment to pregnancy, and the sampling will be a capillary sampling for neonatal venipuncture for the mother at delivery. And we'll screen, as I said, TORCH. We are going to use a free app, which most of you already know, the Global Birth Defect app, which is a decision support, diagnostic support tool in the field. For the qualitative component, we have a feasibility and suitability assessment of this app for congenital abnormality diagnosis, and we'll try also to have an explanation from the mothers and other stakeholders to determine the factors that are leading to microcephaly and congenital abnormalities in our settings. We'll also assess the health system for congenital abnormality management through semi-structured interviews with health authorities, the app users, and pediatricians, and we administer a questionnaire for the app evaluation afterwards. The project started in March 2021 and is running for 2 years. We just completed the preparation activities now, and we submitted the protocol for ethical clearance, and we are now translating the app in French because the 2 countries implementing the study in the Francophone part of the Sub-Saharan African country. Then we'll study enrollment hopefully in December, and hope to complete this study by February next year. As you can see from this, our study is going far beyond Zika and infectious disease, and we want to contribute to fill the knowledge gap on congenital abnormalities by generating the data that are lacking in this field. It will also set the basis for immediate preparedness to potential Zika epidemics, if any, and it will help to strengthen capacities and support the congenital abnormalities, better diagnosis, management, and reporting in our setting. This project will also help to contribute to improve maternal and infant health. The question will be now, how cost-effective will be is to have a systematic TORCH screening in low and mid-income countries, given the variety of resources. For this project, we will contribute to birth defect surveillance worldwide, and this cannot be achieved without collaboration with other networks and consortia such as this ESCAN, with inviting us for this webinar. We are working with a multidisciplinary team composed of epidemiologists, social scientists, and biologists, with PI being Dr. Alice from CRSN in Burkina Faso. So we want to say thank you to all our partners, particularly our founders, the African Academy of Science, for granting us this project through the stream of the Grand Challenge for Africa. And also we want to say thank you to WHO, TDR for giving us, for supporting us in the evaluation of the app and the translation of the app to run this project. And thanks to the Centre Suisse de Recherche Scientifique, the Charité in Berlin, Colorado University and London School and the University for developing this application for this project. Thank you so very much for your kind attention.
Thank you very much, Dr. Nebier, for that very interesting presentation of your study and the various elements, both quantitative and qualitative. So it really looks like an exciting project. We're looking forward to hearing more about it. I'm going to open up for any questions from the floor. We have one question that I think perhaps all our panelists can help with. The question is that we are having cases of increasing cases of NCDs, and I presume that means non-communicable diseases in sub-Saharan Africa. Is there any monitoring systems in place for the possible effects of drugs used to treat non-communicable diseases? Because we've heard about antiretrovirals, Zika, and infectious diseases. And particularly considering the low consumerability of the possible and use of family planning services. Are there any systems that are particularly looking at drugs used for non-communicable diseases? And perhaps maybe any of the existing platforms that can look and have the potential to look for non-communicable diseases. Maybe I can start, Rebecca, maybe you'd like to weigh in on that. Drugs like valproate, the non-steroidals, etc., where we do have some knowledge about safety and how big a problem those are in our countries. Thank you.
Yeah, I think that this question brings up very important point that, yes, we focused on antiretrovirals because those were what we did, but there are now lots of, many other medication exposures in pregnancy, and that it's really important that we build these systems to do this work in sub-Saharan Africa in places that may not only, the exposures may differ. There is probably more of certain diseases and more of certain medication use than in places where there's more systemic surveillance like the US and Europe. And so I think, as the WHO team said, and as Tsepamo is doing, I think we are working to expand to include a lot more of these systems that can then capture medications. In Tsepamo, we are capturing a lot of, for example, antihypertensive medications, chemotherapies, antibiotics, and we can look at that. But I think, really thinking about these systems going forward. And I know South Africa, there's a lot of places doing this work, and this is a very, very important topic.
Thanks very much. And I agree. I think we can use the existing platforms we have, but I think it does raise your point about the importance of having sustainable systems that allow us to collect this data over time with changing new drugs being introduced into the population on an ongoing basis. So it's really important that we have one pooling of data into a registry like a pool project like WHO, and also to have systems which are more sustainable. I have another question, but Noha, would you like to also comment on that point, please?
Just to say that I know I agree that this is a very important topic, and as new medicines are in the pipeline for various diseases, and it's more and more common. And then even with the older drugs, for example, like as you mentioned, sodium valproate, it's really important that these registries do exist. And I mean, WHO helps, and in terms of system, WHO have help with building systems and strengthening systems. So it's something that WHO would be very involved with. Over.
Thanks, Noha. And I suspect that by pooling the data from various settings across the globe, one has greater power in being able to look at drugs that may be used in a relatively small number of people in just one setting. So thank you. Rebecca, if you're still available, Helen Dolk is asking, could Rebecca and Modiehi comment more on how to include affected communities in the pregnancy drug safety surveillance? And thanking you for the fascinating presentation. Thanks.
Sure. I mean, I can just say briefly that I think there's a lot of community-based organizations really around the world that can advocate or can represent communities living with HIV or other, whatever you're studying, and that engaging these groups again is so important. I think in the methodology level, you learn a lot about what actually is happening, who's actually taking what, and what other exposures might we be missing. And then certainly in the communication of results, what will this mean for you and your communities? What are the things does this message make sense? And so I think identifying those community groups in advance is extremely important, and is something that we're hoping to do moving forward.
Thanks, Rebecca. And one more question is, this is from Jessica Nakibuka from Uganda. She's a neonatologist in one of the public hospitals, and she wanted to know whether the Tsepamo team noted any other neurological deficits, even subtle, in the 2018 cohort of babies, if they were prospectively followed up. She's particularly curious to know whether in the non-NTD group, whether there were any other manifestations of neurological problems.
So, Tsepamo was designed just as a birth surveillance. So we only collected data at the time of delivery, and we didn't have follow-up. And so we were unable to look at things like neurologic outcomes. There are other ongoing studies in Botswana now, primarily led by Dr. Shaheen Lockman, looking at neurodevelopment. And the initial studies were done before dolutegravir, and there's ongoing studies now. But I think this is one of the areas, we didn't really touch on here, but there are a lot of things that happen after delivery that birth surveillance doesn't capture very well. And so in addition to increasing surveillance in general, I think figuring out ways to look at longer term outcomes in these settings is also going to be hugely important going forward. Absolutely.
Thank you. Modiehi, would you like to add anything?
Yeah, just to add on what Rebecca has said, it is very interesting that there's neurological studies that are being done in Botswana now. They're also focusing on exposure to DTG and efavirenz, of which could be very, very interesting to look at these outcomes. Thank you.
Absolutely. And thank you very much, Modiehi. And I really want to say thank you to all our speakers for really excellent and stimulating discussion. Also to our attendees for their wonderful questions. And it's time to end now. So I want to thank you all for this wonderful webinar. And you can see the recording of this webinar on the Global Health Network's website. So please feel free to have a look at that and share that with those of your colleagues who couldn't make it. Thank you very much and goodbye. And thanks very much to our colleagues who gave wonderful presentations.